Okay, good morning, everyone. Uh, as always, on Monday morning, we are here to discuss a very important topic because in palliative medicine, we keep getting such patients with altered mental status. So, how we should approach where there are many situations where we can reverse the situation and how we should approach and how we should decide about the fate of the patients or goals of the care. This will be discussed by our team. Our team is the speaker is Karanvir Singh. Karanvir is our third year junior resident of palliative medicine in our department, and his thesis topic is quality of life and incidence and anxiety and depression in COVID-19 patients diagnosed with mucormycosis, and his key area is onco-palliative care. So, and this will be moderated by Dr. Nishkarsh. Dr. Nishkarsh is professor in our department. And I just want to say that yesterday only after like almost 3 days conference of almost a year preparation, he has finished. And today he is here as he was an organizing secretary and a lot of hard work he did. And yesterday evening, late evening, he finished this conference. And today he is here to moderate this class. Thank you, Nishkash. And he has written a book, Update in Onco Anesthesia, and plus also he is also editor of Problem Oriented Palliative Care book, which is going to be published by Oxford University of Press. Uh, mm, he has got a lot of actual publication and a lot of things I can say, but I we should start. But I also want to say that we have a set facility where he is an adjunct faculty, and he received Best Researcher of the Year and Best Reviewer of the Award by Indian Society of Anesthesiology. So thank you, Nishkash, and thank you, Karanveer. Please start. Thank you very much. You can write your questions in the chat box, and they will be Nishkash will answer at the end. Thank you, Nishkash. Go ahead.
Thank you, ma'am. So, Karanvir, you can start. So, we have tried to focus on approach to a patient who is having an altered mental status. So, he'll take you through all the journey. What are the possibilities? How do we assess them? And what do we do with respect to this patient by giving an example of a case? Karanvir, you may start.
Very good morning to one and all who have joined this early morning session. I am Dr. Karanvir, JR Palliative Medicine, and my moderator for today is Professor Nishkarsh Gupta, sir. Today we are going to cover a very vast topic. To make it very clear from the beginning, I won't be bombarding you people with endless list of conditions that may end up in altered mental status. Rather, my focus of the session will be to teach basic clinical points of neurological history taking examination and their clinical application for the care of the patient. In my talk, I will be focusing more towards the comatose patient, and I will be focusing on the coma patient because it is itself is a very vast topic, and in the limited time allotted to me, I will try to do justice to the topic, and I hope this is a learning experience for all of us. So, beginning with the introduction, we will begin initially by reviewing the definitions and anatomy of the conscious state, thereby applying those points in the diagnostic assessment of the patient, where we will discuss the practical points of history taking and examination. Also, we will cover important basic radiology in the assessment of the patient with AMS, which is an important skill needed to be a good clinician when dealing with such complex patients. From the points we have learned during this talk, we will then move on to a case scenario, which will be inclined towards a combination of a neurological and a palliative care aspect. After the case discussion, we will just go through some important differential diagnosis, which will be mentioned throughout the PPT, but will be emphasized here in the section. So last but not the least, we'll conclude with a take-home message. So let's begin. So introduction, the workup of a patient with altered mental status is often complex and always urgent. AMS is a broad clinical category used to describe disorders of arousal and content of consciousness. The term AMS is often used to describe a variety of abnormalities of cerebral function and is haphazardly used to describe patients who have impaired alertness and cognition or a deficit of higher cortical function. Strictly speaking, the term altered mental status should imply a change in the level of consciousness, somewhere on the continuum between confusion and coma. It should not be used to describe patients who have impaired cognition with a clear sensorium. For example, dementia patients, aphasia patients, patients with psychiatric disorders like psychosis or mania. The reason for this distinction is that these conditions are very different in terms of their etiology and especially have different prognostic implications. And it's the reason we won't be going into details of these conditions in this seminar. So when we talk about the dimensions of consciousness, they're divided into arousal and cognition. Arousal is a primitive function which is sustained by the deep brainstem nuclei and the medial thalamic structures, which I'll show in the later slides. And cognition is a specialized function which requires an intact cerebral cortex as well as the subcortical nucleoli structure. Now, when we talk about the anatomical structures which are responsible for the consciousness, it is the ascending reticular activating system, which in short is called the ARAS, and the thalamus and the hypothalamic complex. So the ARAS arises from the reticular formation, which is in the upper pons and the midbrain, that is the brainstem. Then they projects to the thalamic nuclei and also receives fiber from the spinothalamic tract. And we know that the ARAS fibers, they are a diverse variety of the fibers, which include cholinergic, serotonergic, adrenergic, dopaminergic. You name any neurotransmitter, it is involved in the ARAS system. And when we talk about the thalamus and hypothalamus, they also contribute to the maintenance of the conscious state. And the nuclei and pathways controlling the eye movements also occupy the same regions. And this emphasizes the point that eye examination is a very important part of examination when we are approaching a patient with altered mental status, which we'll come to in detail later. So as we talk that the left figure shows the posterior view of the brainstem, which is showing the reticular formation. The red nuclei, they are widely distributed throughout the brainstem, as we can see, the medulla, the midbrain, the pons. And on the right side, it shows how these projections are entirely going to the full cerebral cortex. So they start from the brainstem, relay in the nuclei, and then they, like a fountain, like a shower, they distribute throughout the cortex. So how it translates into clinical practice is the most important point. So, as we have seen that with an abundance of projections, connections, and multiple neurotransmitters involved, like just mentioned, a normal consciousness and coma can only be a result of widespread dysfunction of the brain and brainstem. Each of the components that help in achieving consciousness that we have discussed so far have their own function. But there is evidence that these pathways are redundant and set to work when one system is down or destroyed so that they compensate for each other. But sometimes we come across situations that a strategically structural location in a lesion in a location can cause the entire system to break down. But for the most cases seen clinically, there is diffuse and multifocal injury, which is the cause of the AMS. Now, when we classify the unconsciousness, it is divided into states of a reduced wakefulness, which is due to the lesions of the ascending reticular activating system and the thalamus, and the states of reduced self-awareness, which is due to the cortical lesions, which we just saw in the figure, which include the cingulate gyrus, the cuneus, the precuneus. But when you're assessing clinically, significant overlap exists between these two entities when the patient is evaluated on a clinical basis. So the spectrum we'll be dealing here with will be coma, prolonged impaired consciousness, locked-in syndrome, acute confusional state, and delirium. This is the spectrum of altered mental state. So moving on to the most detailed discussion of today, which is the coma. Introduction, the terms coma, stupor, lethargy, they indicate a decreased level of alertness. But these terms fail to convey vital information needed for neurological localization and management. Rather than using these confusing terms, a description of the patient's level of responsiveness incorporating some detail to reproducible stimuli is preferred. This approach facilitates better communication among the treating teams, enhances consistency in successive evaluation of the patient, and sets the basis for rational diagnostic assessment. So, for example, Mr. Z was evaluated in the emergency department and he was found to be stupor. This statement alone gives little, if any, information about the patient, which can further help us plan his evaluation. So a better method would be conveying using simple words. For example, Mr. Z was evaluated in the emergency. and he was lying motionless in the bed. Until called loudly by his name, when he opened his eyes, they were looking towards left. He failed to answer any questions or to follow instructions. Now we can see that instead of using a word stuporous, we can just use simple English and it can convey 10 times the more information so that we can think of what is the diagnosis causing altered mental status in this examination. So when defining coma, it is simply defined as a state in which an unaware patient does not awaken, speak, or open eyes and has motor responses that are withdrawal or reflexive and not purposeful. The operational definition was given by Plum and Posner, who were the pioneers in altered mental status pathophysiology delineation. They defined coma as a condition in which the patient is unarousable, unresponsive, and lies with eyes closed. These patients do not have a response to external stimulus or the inner need and do not communicate appropriately. Then Fisher emphasized that coma is a continuum rather than a single state. So it's very important to keep all these points in mind that we are discussing about a continuum. It's not a single point state that we are discussing in the coming slides. So when you're dealing with the clinical examination of a comatose patient, you have to start with observation and inspection. Then we'll test the responses, which we'll come on to later. Combining these findings, we'll do the abstraction and consolidate into a localization. So clinical localization of the lesion. Then we'll move on to the etiological consideration of the causes. And to keep in mind that these above 5 steps, the ability to do all these steps is shaped by the clinical experience, and it includes pattern recognition, knowing what are the likely diagnoses, and the ability to weigh the significance of each finding. That's what the whole thing is about. So when we come to functional anatomy and its application in coma aspect, so the regions affected and the common mechanisms which are involved. When we are dealing with the bihemispheric cortical injury, the reasons are for in most patients are diffuse anoxic ischemic injury, for example, post cardiac arrest or metabolic causes. White matter can be destroyed due to the acute demyelination or acute hydrocephalus. Thalamic lesions can be arteriovenous occlusions or compression by mass lesions. And brainstem lesions can be due to infarction, hemorrhage, or herniation. So these are the common mechanisms which can lead into altered mental status and coma. Now coming on to the important reflex circuit in coma assessment. Cerebral hemispheres, when examining, they can be only examined by gross assessment such as response to sound, touch, or noxious stimuli. So there are not much localizing signs here which we get. But the thalamus and the upper brainstem may produce more localizable signs. When any of the brainstem reflexes are absent, it is useful in the correct localization of the lesion and thus narrows down our differential diagnosis and the etiology. And the ocular examination, as I mentioned in the initial slides, they play a vital role in this assessment. So the important reflexes we are going to be dealing here with are the pupillary right reflex, the blink reflex, the visual tracking, the oculovestibular reflex, and the cuff reflex. Coming on to the application of the pupillary right reflex. As you can see in the diagram that the afferent signal is carried by the optic nerve, which then you can see is entering posteriorly to the midbrain, enters in the pretectal area, and synapses to the Edinger-Westphal nucleus. So the optic nerve, we can see that it relays to both the Edinger-Westphal nucleus. It crosses the midline also, and it supplies the ipsilateral also. And the efferent signal is sent via the oculomotor nerve, which ends up in the constriction of the pupil. So when we shine light into one pupil, both the pupil constrict, direct and consensual reflexes. Now, it is a key prognostication sign in patients with altered mental status, and loss of right reflex portends a poor prognosis. So always check the pupils. Just shining a simple torch light can give us invaluable information. So the pupil abnormalities we see in coma and their implications are discussed here. If these are present, it is one of the hallmark clinical sign in a comatose patient or a patient with altered mental status. So when you see small or pinhole pupils, think of a pontine localization. When you see mid-sized pupils, the midbrain tectum, it means the posterior part of the midbrain involvement is highly likely. And when it is a asymmetric, maximally dilated pupil, then peripheral causes like oculomotor nucleus and the peripheral nerve of the oculomotor nerve involvement should be kept in mind. So when the unilateral fixed pupil is encountered during the evaluation, It can be either due to a midbrain oculomotor complex lesion, in which case only pupil size will be changed. Whereas if the nerve is being compressed due to a mass lesion or something is pushing the nerve down, along with the pupil size changes, we may also see deviation of the eyeball and the ptosis, because the levator palpebrae superioris is also supplied by the oculomotor nerve itself. So there are some varieties of pupil abnormalities which may see. Beginning from the left side, the top column shows a unilateral dilated, maximally dilated pupil. So it can be due to oculomotor palsy, as we discussed, from an acute intracranial mass or contusion of the bulbous oculi. The second slide in the middle on the left side shows a oval-sized pupil. Oval-sized pupil is a very ominous sign. It can be seen in a appearance when the patient is about to undergo brain death. Maximal dilated pupils bilaterally, as shown in the lower left segment, is due to drug side effects or the vasopressors which we are giving, or atropine which may be given during cardiac resuscitation. So it should be kept in mind. On the right side, when we see the mid-position pupils, they are ominous and they are significant of brain death or a mesencephalic lesion in the posterior part of the midbrain. The Horner syndrome shows a small pupil, like we talk about a triad of anisocoria and small pupil, and ophthalmos. So it can be seen in carotid dissection. It can be seen in injury to the sympathetic chain supplying the sympathetic fibers to the pupil. And finally, the total pinpoint pupils can be seen in opioid toxicity and acute pontine lesions, as well as in non-ketotic hyperglycemia and hypercapnia. So we have to keep the following diagnosis in mind with the clinical history of the patient while assessing the pupil abnormalities. Now we come on to the second reflex, which is the blink reflex arc. In the blink reflex arc, the examiner exposes the patient to a loud sound, and in the second part, he approaches the patient with a rapid hand movement towards his eyes. So when the loud sound is given, it is called the acoustic arch. The acoustic arch is through the brainstem and doesn't need a cortical input after a loud sound. So even if the cortex of the patient is destroyed and you loudly clap in front of his ears, they might blink. But when you rapidly approach a patient with your hand towards his face and the patient blinks his eyes, that movement needs an intact visual cortex, because blinking after a visual stimulus needs an intact visual cortex. So these tests can be used to examine patients with severe bilateral hemispherical lesions, as seen in the persistent vegetative state patients. So the vegetative patients may blink their eyes when you are clapping loudly, but when you approach their eyes with a rapid movement of the palm, they will not blink their eyes. So it is very important, which it's a test which we all remember and assess regularly in our patients. When coming to the visual tracking, it means you are showing your finger to the patient and asking them to follow the movement of your finger. So the diagram here shows that the frontal lobe of the brain, it controls the contralateral paramedian pontine reticular formation. That is, the left side frontal lobe will control the right side PPRF. And the pontine reticular formation then relays the signal to the abducens nuclei and the opposite side oculomotor nuclei via the medial longitudinal fasciculus. So the visual tracking requires coordination of the frontal lobe, coordination of the pontine reticular formation, the abducens nerve, the medial longitudinal fasciculus, and the oculomotor nerve. So when you are asking the patient to track your finger, you are actually checking all these things. And if he's able to track, that means all these things are working. So more or less, all of the brainstem itself is working, because third cranial nerve emerges in the oculomotor, the sixth cranial nerve emerges in the pons. So you are checking all that brainstem just with a simple movement. So the implications are, as a general rule, with normally evoked conjugate eye movements, the center for horizontal gaze and medial longitudinal fasciculus are spared. And this indicates a largely intact brainstem. Conjugate gaze deviation is due to lesion of one hemisphere and is directed towards the abnormality and contralateral to the hemiparesis. If the eyes are deviated on the side of hemiparesis, we infer a thalamic lesion and a brainstem lesion which disrupts the MLF. So if this MLF is disrupted, so the sixth nerve won't be able to communicate with the third nerve. So when you are asking the patient to turn their eyes towards one side, the one eye will shift outside, but the contralateral eye won't shift towards the inside because the connection between the 6 and the 3 is lost here. So that is called intranuclear ophthalmoplegia in technical terms. So these are the visual tracking and its implications. When we come on to oculocephalic and oculovestibular responses, it is the same as visual tracking, but indirect connections occur through the semicircular canals of the ear. So instead of tracking the eye movements, we can just rotate the head of the patient and see the eyes shift to the opposite side deviation. If the patient is unconscious, we can check it with the irrigation of the ear canal also. So when you rotate the head towards left, the left side of the semicircular canal, left ear gets activated and it causes the eyes movement to the right side. Similarly, from when you stimulate the right side ear, the eyes will move towards the left side. So the uh, response and its implications are when the lesions are above the brainstem, that is supratentorial lesions, and metabolic processes, they usually do not affect this reflex. How we do is we flex the head to 30 degree and 10 to 20 ml of ice cold or warm water at body temperature is instilled into the ear canal. And the tonic deviation of the eyes can be seen after 15 seconds to 60 seconds. In case a patient is comatose, the eyes will remain deviated. They won't correct back because there is no corrective nystagmus. Corrective nystagmus requires an intact cortical loop. So the eyes will deviate ipsilaterally in case of cold water and opposite direction in case of warm water irrigation. And in coma, the absence of this reflex, it suggests either a sedative hypnotic intoxication or a brainstem structural lesion, as we talked, internuclear ophthalmoplegia, or brain death if there is no previous vestibular disorder. So it's a very important reflex to check in a patient with altered mental status and a comatose patient. How do you check the cuff reflex? So it is to be re-emphasized that inspection of the mouth and oral cavity should never be neglected. The discoloration by the corrosives due to a suicide attempt or due to a tongue bite during an unwitnessed seizure can be noticed, which can help us in detecting the etiology and further planning the management. The cuff and pharyngeal reflexes are better tested using a suction catheter in the endotracheal tube. It tests the cranial nerves 9 and the efferent nerve is the cranial nerve 10, which is the vagus. So having discussed all these reflexes, we'll move on to the clinical decisions which need to be taken when assessing a comatose patient. So initial parameters, apart from ABC, which include the airway breathing and the hemodynamic status, we need to focus on the use of the prior drugs or sedatives or neuromuscular agents. So when coming to the airway and breathing, stridor, decreasing saturation, tachypnea, they are indications for consideration of intubation given the correct conditions and the goals of care, which will come on to later. But when you have to intubate the patient, if available, etomidate is a useful drug for rapid sequence intubation because it mutes the ICP changes and has little hemodynamic effects, thereby making it a safer drug in this category of patients. When the patient is having hypotension or hypertension, always first rule out hypoglycemia. Number one rule, never miss hypoglycemia in a patient with altered sensorium. If there is hypotension, manage it with crystalloids and IV fluids. And hypertension, a mean arterial pressure of more than 130 mmHg needs to be managed with labetalol and intravenous nicardipine. The sedatives and neuromuscular blocking drugs are a major confounder in neurological examination because once you have to assess the response of the patient, if he's using a neuromuscular blocking agent is given during intubation, we may not observe any response and we may falsely interpret the coma scale, which we'll come on to later. So this is a list which of the common drugs used during intubation and during patient transfer from the peripheral hospitals to the apex centers. During the ambulation, during the ambulance travel, they may be given such drugs. So this needs to be inquired into detail and the time frames need to be kept in mind when going to approach a patient with altered mental status. So the further questions, once you have done and stabilized the patient primarily, the further questions to family or bystanders need to be asked. And the questions regarding intoxication include the all medications the patient was having access to, including the oral over-the-counter medications, any history of prior suicide attempts or psychiatric evaluations, any alcohol intake patterns which need to be kept in mind. Environmental injuries include where the patient was found, any history of recreational activities like diving or recreational drug use like cocaine and amphetamines need to be kept in mind, especially in young patients presenting with the AMS. For the history of trauma, the nature of accident, and whether the patient was breathing on the way to a hospital or any blood loss which occurred during the transport need to be kept in mind. When you are taking a suspecting infection, any use of antibiotics in the recent past, any history of rapid onset fever or severe headache with fever should be kept in mind. During cases who have underwent cardiopulmonary resuscitation, any cardiac arrest which was documented, if yes, how long was the CPR given, and was there any abnormal movement seen after the CPR, which is commonly called as Lance-Adams syndrome, and we'll discuss later. In case of patients known diabetics or a known case of cerebrovascular diseases, was there any history of diabetic ketoacidosis or episodes of hypoglycemia? Was there any history of atrial fibrillation or any anticoagulation the patient was on? So all these factors need to be kept in mind while assessing a patient who cannot speak for themselves. Physical signs in AMS which indicate a systemic illness or a drug toxicity or a toxidrome, which we call. So we may observe hyperthermia, the patient running a fever or a low body temperature. We may see patients with hypertension or hypotension, elevated heart rate or a low heart rate, rapid breathing or a shallow breathing, and a slow ventilatory rate, sweating, dry skin, or odor, which may be noticed on clinical examination. And here is the list of causes which we need to keep in mind, which I won't be going into an exhaustive detail. So we need to keep these factors, the clinical signs, and the common considerations which need to be kept in mind are emphasized here. So now we come on to the scales which were used for assessing coma. The most common we all know is the Glasgow Coma Scale, which consists of the eye movements, the motor response, and the verbal response. So the eye movements are scored from 1 to 4, the motor is scored from 1 to 6, and the verbal is scored from 1 to 5. So here are the figures. When the eye movements is nil, eye movement, the score is 1. When the eye movements is to pain, the score is 2. Eye movement on speech, the score is 3, and spontaneous eye movements is 4. Similarly, all the vocal and the motor responses are graded accordingly, as shown in the figure, which you can go through. And coming on to the more important part for us, which is the limitations of the GCS. So GCS has difficulty detecting more subtle abnormalities of arousal, does not assess the brainstem function and respiratory patterns. So eliciting verbal response, we commonly come across that it is not possible in endotrachely intubated patients, where we just go and write E, V, T, and then we see the motor response. And most of the time they are placed on sedatives or neuromuscular blocking agents, which we cannot again assess the motor response also properly. And suppose you come across a patient with a swollen eyelid from a trauma or a surgery, and the GCS can only assess the motor response. And that too, if the patient is a polytrauma patient with a C-spine injury, the motor response will also not be accessible. So the entire scale is rendered useless for a neurological examination. So these are the limitations when we come to the GCS. So the committees, the expert committees, they devised another scale, which is called the full outline of unresponsiveness or the 4 score. It has 4 testable components, and each component has a score of 4, which we'll be focusing here. We assess here the eye responses, which include the eye movements and eye opening, the motor responses as assessed in GCS, the brainstem reflexes, which were not at all assessed in GCS, the pupil, corneal, cuff reflex, all of them are assessed here. And even the respiration we see, whether they are spontaneously breathing or they are mechanically ventilated, is also taken into account. So when we come onto this scale, it may look daunting, but when we see the eye responses, 0 means the eyelids remain closed even with pain. 1 means they open to pain. 2 means they open to loud voice. A 3 is a very tricky situation here because the eyelids are open, but specifically see that eyelids are not tracking. So we know that tracking of the horizontal eye movements is a very important part and requires a cortical input, as we discussed just recently. And a score of 4 means eyelids are open, they track, they blink, they do everything to command. So that is a score of 4. In motor responses, 0 means a no response, 1 means extensive response, 2 means a flexion response, 3 means localizes pain, and 4 means it does a thumbs up. The patient does makes a fist or he does the peace sign as shown in the figure when asked by the examiner. The brainstem reflexes, 0 means there are no brainstem reflexes, no pupil reflex, no corneal reflex, no cuff reflex. The 1 means pupil and corneal reflex both are absent. 2 means either pupil or corneal reflex is absent. 3 means a unilaterally dilated and fixed pupil, which we also talked that how important it was to look for the pupil in the case of AMS. and 4 means bilateral corneal and pupil reflexes are preserved. When we come on to the respiration, 0 means the patient is fully in synchrony with the ventilator and he breathes at the ventilator rate or he is having apnea. 1 means breathes above the ventilator rate, that is having spontaneous breath of his own as well. 2 means he is not intubated but having an irregular respiration. 3 means not intubated with a Kind-Stokes breathing pattern, and 4 means a regular breathing pattern. So when you get 0 on all these scales, it's time to think about possibility of a brain death after ruling the causes of all confounders like hypothermia and toxidromes and drug side effects. Now, the advantages of a 4 score, it not only measures eye opening, but also assesses horizontal and vertical eye movements, which assesses the brainstem integrity as we just saw. It can detect locked-in syndrome, even if the GCS is a minimal of 3, because it can track the eye movements, which are a very critical point in recognizing locked-in syndrome, which will come into later detail. It can even detect the presence of a persistent of the vegetative state, where the eyes are opening spontaneously, but they are not tracking the finger of the examiner. And the motor response also includes myoclonus, which is a very poor prognostic factor after CPR. The hand position tests like the fist sign, the peace sign, they were also used to assess alertness, and the validity also has been tested in especially in neurological ICU patients. It doesn't include a verbal response, and this is more valuable in the ICU patients where most of them may be intubated. So when we come to major clinical syndromes in coma, it includes the bihemispherical syndrome. So bihemispherical syndrome occurs mostly secondary to acute metabolic derangements, toxins, or ongoing seizure or a post-ictal states. So the important thing to keep in your mind is patients may have very few localizing findings. They may respond to voice, but then eventually they may also respond only to pain. The full spectrum of the motor responses may be seen, and the myoclonic status epilepticus may be seen in severe anoxic injury, post cardiac arrest in CPR survivors, and is a very poor prognostic sign for a very bad neurological recovery. Intrinsic brainstem syndrome, as we can see in the shaded area, the entire brainstem is shaded. So the patients present with instantaneously with a failure to open eyes and even to a painful stimulus. So we can see E0. Withdrawal motor response and at best external posturing is seen, which is a very bad motor response. Anisocoria may be seen, and there may be dysfunction of the medial longitudinal fasciculus also. So we may be seeing abnormalities in the vestibular ocular reflex, or the vestibular ocular reflex, that is the VOR, may totally be absent in these patients. The presentation of signs at onset without much later change points to this pattern. So, except for the patients can then finally develop loss of all brainstem reflexes, which is called the brain death. Locked-in syndrome, you can see that it is a very specific area which is shaded in the diagram, the upper pontine area. It very closely mimics the intrinsic brainstem syndrome, but there exist subtle differences. So spontaneous vertical eye movements may be preserved in these patients, so which, if unrecognized, you can diagnose it mistakenly as a brain death. When in reality, the patient can hear you, the patient can feel you, and the patient can do everything, but he cannot move. So the extensor posturing may be seen, ocular bobbing needs to be recognized, but it needs a considerable experience to recognize it. And this syndrome is mostly caused by occlusion of the top of the basilar artery. Lateral brainstem displacement syndrome means you can see that a lesion is causing a force laterally. So it distorts the thalamus and the midbrain, and sometimes the force extends to the upper pons also. Here we can see a unilaterally fixed pupil in the earlier stages due to the cranial nerve 3 nucleus involvement, which is in the midbrain. Pontine reflexes are preserved in most patients, and thalamic hemorrhage can also present in such a way. And lateral brainstem displacement can also occur due to cerebellar lesions. Here it was occurring due to a cerebral lesion. Here it is due to a cerebellar lesion. But when it is due to a cerebellar lesion, the main force is on the pons. So the pontine reflexes are the ones which are most lost. And there may be bilateral meiosis, as we saw that bilateral small pinpoint pupils may be seen in pontine lesions. So here we can see the figure drawing, and the clinical features are mentioned. Now there's a concept of central brainstem displacement. Here, a lesion from above, it displaces the thalamus and the midbrain in a vertical plane. So when the midbrain is upfront involved, the first abnormalities to be encountered will be the pupil abnormalities, because The pupil, the oculomotor nerve, it arises from the midbrain only. So asymmetric compression may cause a unilaterally dilated pupil, and varying motor responses may be seen. If not treated or recognized, it can then end up compressing the whole brainstem, and first the loss of brainstem, midbrain reflexes, followed by pontine reflexes, followed by medullary reflexes can occur if not recognized and not treated. So this is the central brainstem displacement syndrome. Coming on to role of imaging in coma evaluation. So after a focused history taking and a neurological examination, a clinical localization is made. To confirm the localization and to narrow down the vast differential diagnosis, imaging plays an indispensable role in achieving the clinico-radiological diagnosis. So when the neuroimaging results are normal in patients with AMS, we as physicians face an uncomfortable dilemma about how to proceed further with the care of the patient. And CT of the brain, in particular NCCT, is most frequently used imaging modality and the quickest test to find the possible structural causes. So CT is invaluable for understanding causes of coma and addressing severity of the mass effect, which I'll come on to later, that how we see a mass effect. Artifacts on CT are minimal except in the posterior fossa. So when you're about to assess the posterior fossa, which is the cerebellar part, the CT is not the best modality of choice. NCCT is most commonly performed as it can be easily and quickly performed on an emergency basis. And keep in mind that a normal CT is expected in cases after cardiac resuscitation or asphyxia, near drowning, intoxications, and acute metabolic disturbances. So here is the reading guide of CT scan to the brain, which you can go on later, which suggests to look for the bone windows, to look for the ventricles, the parenchyma for any bleed, and the arteries, and the causes are mentioned. The role of MRI comes when CT is non-conclusive. So MRI is much more revealing and demonstrating an anoxic ischemic injury, acute demyelination, and encephalitis of the brain. In these all cases, CT may be totally normal. With contrast enhancement, it can even demonstrate meningitis, this HSV virus, and the limbic encephalitis. Sagittal and coronal sections are very important to demonstrate brain tissue shift and brainstem displacement. And the most important sequences we need to keep in mind is the FLAIR, which is the fluid attenuated recovery, in which it's T2 sequence, but the CSF is suppressed down so that we can see the pathological fluid, and the diffusion weighted imaging, which is the measuring the water diffusion through the tissue, which in normal conditions is restricted because blood-brain barrier allows very specific things only to pass. But in pathological states, the water movement is increased. So it can be useful to see the cases of unexplained AMS which are not picked up on CT. So here is the MRI reading guide, which you can go through later. I won't go into the all distinct causes. Now, coming on to a case scenario. So the case here goes as follows. Mrs. RB, a 66-year-old lady, a known case of metastatic carcinoma gallbladder with history of rheumatic heart disease, diabetes mellitus on oral hypoglycemic drugs, and prosthetic mitral valve on tablet warfarin since the last 25 years, was diagnosed with CAGB 5 months ago and started on palliative chemotherapy, gemcitabine and oxaliplatin, of which she had received 6 cycles, following which her scan shows disease progression and she was planned for second-line chemo by the MO team. Around 2 weeks ago, she started developing gradually progressive jaundice and was advised for PTBD, that is percutaneous transhepatic biliary drainage, screening by the primary team. The patient presented to the emergency one day before the date of procedure with complaints of decreased responsiveness prior to presentation. According to the relatives, she went to bed at normal time but didn't wake up on the usual time and was found unresponsive. Now the emergency sent consult to the medical oncology team and palliative medicine team to plan further care, meanwhile assessing the case. So metastatic CAGB, rheumatic heart disease, diabetic, prosthetic heart valve on anticoagulants, and progressive jaundice. This is the scenario we are talking about. So on examination, the heart rate was around 60, the respiratory rate was around 10 per minute. The BP was shooting up to 190 by 120. The SpO2 was maintained at 95% on room air, and the VBG parameters, pH was within normal ranges. PCO2 was slightly elevated at 56 mmHg, and PO2 was 45. Bicarb was 31, and RBS was 148 milligram per deciliter. The systemic examination shows icterus, which is severe, and normal breath sounds, but the patient taking slow, deep breaths. The S1, S2 were heard normally. Hepatomegaly was present on abdominal examination. The GCS was 7, E1, V2, M4. The patient was not moving the left upper limb or left lower limb, even on painful stimulus. Only withdrawal of the right upper limb and lower limb was seen during a painful stimulus. When checked, the right pupil was dilated, non-responsive to light, left was normal. Facial grimacing was absent on the left side. Vestibular ocular reflex was impaired because the right eye was not moving medially but was able to abduct while attempting the VOR. The deep tendon reflexes were non-conclusive. So, how do we approach this case? Recall the key findings of the history, the general as well as the neurological examination, and possible differential diagnosis for the non-responsiveness. In this case, the possible causes can be, we can keep hepatic encephalopathy as a cause because icterus was present on examination. We can keep hypoglycemia-induced encephalopathy because she is a case of diabetes mellitus on oral hypoglycemics. We can keep warfarin-induced intracranial bleed because there is a long-term use of warfarin for RHD and prosthetic heart valve. Undiagnosed metastatic brain disease may be a cause, but it is uncommon in CAGB. And acute liver failure because there is a rapid onset of jaundice and encephalopathy with coma. And there may be other causes which may not be clear from the history and examination. So these are our DDs. And to see what pattern of etiology from the history and examination will fit the case more appropriately, we'll discuss these possibilities. So hypoglycemia, we know that it will usually have a preceding symptoms of sympathetic overactivity, sweating, palpitations, non-localizing neurological findings, but it needs to be rolled out upfront as it can be a great stroke mimic. And we know that in our patient, the emergency people did a VBG and RBS, it was 148. So it is not low. Hepatic encephalopathy usually has a waxing waning course and sleep phase disturbances preceding the non-responsiveness stage, and it is usually not accompanied by focal neurological deficits. Brain metastasis may have a preceding stage of features of raised ICP, headache, non-specific complaints, and they are less likely to have localizing focal neurological deficits. So, in our case scenario, findings of a right fixed dilated pupil, left-sided hemiplegia, including facial palsy, and impaired pontine reflexes, which is the VOR was impaired. So the suspected lesion is causing ipsilateral cranial nerve 3 palsy, that is the oculomotor palsy, due to which the ipsilateral right eye is not moving medially because it is causing traction on the oculomotor nerve, and the pupil is also dilated. So, and when the midbrain is compressed, the cerebral peduncle and the facial fibers are also compressed, and it will lead to contralateral facial weakness and contralateral weakness of the body. Along with this, we see that there is slow breathing and hypertension, which points towards a possibility of raised ICP, Cushing triads, and the suspicion of a brainstem herniation as well. So, since we have localized all these findings, it is localizing to a lesion involving the brainstem at the level of the midbrain. Now, if it is untreated, it can even later stages progress to involve the whole brainstem from above to down. So, what next? As we have discussed in these slides, we have to order imaging and look for the structural cause. And routine blood investigations needs to be done. And ECG is a must to rule out any arrhythmia. Important landmarks on how to identify brain tissue shift. So we see that in a normal CT scan, the blue areas are the cisterns. So when these cisterns are very symmetrical, there is no brainstem shift which can be appreciated. So the ambient cistern, quadrigeminal cistern, supracellular cistern. But in our patient, what we found was these findings. So you see on the left side ambient cistern, the orange arrow is wide open, whereas the right side is totally obliterated. And we can see a huge subdural hematoma. And well, assessing the midline shift, you can see the deviation of the septum pellucidum on the right side and the deviation of the pineal gland also, which is pushed towards the left and causing a hydrocephalus. So this is the NSCCT in our patient, which showed acute subdural hematoma causing lateral brainstem displacement syndrome, which we discussed in the slides. So a cerebral lesion compressing the brainstem and causing the impairment of the brainstem reflexes. When you see the MRI, you need to keep in mind the following parameters, which is used to find out the shift, which is determined better by MRI as compared to CT. So back to our case, a diagnosis of acute active right SDH was made based on the CT. Swirl sign was positive, as we can see in that CT scan, and plan was made to call the neurosurgery team for evaluation. Etiologically attributed to warfarin-associated bleed, superimposed with progressive cancer-related liver dysfunction and coagulopathy. Bedside ultrasound was suggestive of extensive replacement of liver parenchyma by the metastatic disease. MO team deemed the patient unfit for any disease-targeted treatment. INR of the patient was 6.5, and unfortunately, the neurosurgery refused to operate without optimization. Within next 1 hour, despite FFP coverage and vitamin K administration, medical decompression with mannitol and all, the GCS of the patient dropped to E1, V1, M1, and the palliative team was called for further planning of the patient's care. So when we talk about palliative care in altered mental status and coma, a very important part of palliative care is knowing when to treat and when not to treat, and formulating a care plan for the patient, keeping in mind the person inside the patient and the biopsychosocial aspects of the patient care. It involves attaining of a balanced approach that will help the patients and families take decisions which align to their goals of care. Unfortunately, there are instances when critical decisions regarding prolongation of life versus withholding of life supports have to be taken at a time when they are least expected. In such situations, critical skills of the palliative team come into play. By being empathetic towards the patient and the family, having open and honest discussions regarding the plan of action and the prognosis, and maintaining emotional and psychological support throughout the conversation is what makes the conversation successful in these difficult situations. There are instances like the case we have discussed when difficult decisions regarding the end of life discussions may need to be held with the family soon after the presentation of the patient in the emergency room. That too, not having met the patient even once before. So, after this consideration of the patient, disease biology, the family caregiver, and ethical and care coordination aspects, we can hope to achieve a plan for the patient, even if the plan means that he or she cannot be saved. Having a plan is all that matters and signifies non-abandonment of the patient, which is a very important aspect of patient care in palliative medicine. So these are the outlines of the holistic assessment which needs to be done, the care coordination which needs to be done with the neurology and neurosurgical teams, and the ethical considerations which need to be kept in mind. So applying all these principles to our case, our patient had refractory coagulopathy, probably due to the metastatic nature, the liver failure, and the progressive disease. So the GCS rapidly decreased. The family was counseled regarding the non-reversibility of the condition despite FFP and vitamin K coverage. She was not improving, and they were explained that the neurological outcome will be extremely poor. The care preferences were inquired, and they were explained about the possibility of cardiorespiratory arrest due to brainstem compression and herniation. And after explaining and understanding the situation, the family members agreed for do not intubate, do not resuscitate, and were willing for the disease to take its natural course. They were explained regarding the futility of further neurosurgical interventions and the blood product transfusion as well. So the patient expired 12 hours after the admission to the emergency department in the palliative medicine ward. So this was the case discussion we just had. Now, coming on to the final part of the slides, we have conditions that may be confused with altered mental status, one of which includes the persistent vegetative state, which we have talked about many times in the seminar. The criteria for PVS is mentioned here, which you can go into details later on. The scan shows cerebral atrophy and severe ventricular dilatation, which is seen in the cases of PVS. Minimally conscious state is an other differential diagnosis, which is slightly better than the persistent vegetative state, in which the patient has some form of environmental awareness, but still is a very high level of neurological disability. The exact criteria you can go on later. And acute confusional state and delirium in itself, it is a whole lecture if we come on to detail. But these are the few clinical features of the delirium which are mentioned, that it typically develops over days, and disordered attention and acute fluctuating course are the hallmarks of delirium. There's a screening method which is called the delirium screening method, the BCAM, which is called, and you can go through all these features later. The focus of our seminar was to focus more on the comatose patient and the structural causes of coma. So the take-home message: in the evaluation of a patient with altered mental status, keep in mind the following. Recall the key findings of the neurological examination, as we have re-emphasized. Review the CT and confirm that it is normal. MRI may be needed in diagnostic dilemmas in certain cases. Always think of a toxidrome and look for it. EEG is not helpful in acute situations. AMS resolves quickly if an antidote is available in cases of intoxications, but the vast majority of intoxications, they are managed with supportive care. Any febrile patients with AMS should get an antimicrobial coverage. And if situation still remains unclear, consider uncommon presentation of common diseases rather than rare diagnosis upfront. And last and not the least, know when to treat and when not to treat. So thank you for being such a patient audience. I welcome any doubts for the session.
Nishkarsh,
Sure. So very well presented, Karamveer. So there is a question before we close. So Karamveer, can you come to the last slide, the concluding slide? So someone has asked, do we have a minimum mandatory documentation required for unconscious patient which we need to follow? Karamveer has been very clear in his talk, and the take-home message mostly gives your answer. So whole idea is that if the patient has an altered mental status, when we label him as having an acute coma or a coma-like state, we need to be very sure what is the cause for this situation. So we need to see, we should have a good clinical examination, history taking, and maybe an investigation like CT scan if feasible, and if the clinical examination warrants it. We need to basically document what is the possible cause and is it reversible or not, and can we do something to reverse the situation. So that is a must, because otherwise it becomes really difficult, and this kind of situations can be tricky to handle. So once you are sure about it, you know the cause, whether it is a toxin or a febrile status or a brain metastasis or any other situation. There can be hundreds of causes. And if it is non-reversible, then we can start the care pathway plan, as Karamveer stated in the one of the last slides. We have specifically not focused only on palliative care, because these are situations which are very common, and they will be occurring across specialties, whether it is neurosurgery, neurology, oncology, general medicine, general surgery. So we need to know what is important in assessment part of it. So that's why he has covered a lot of clinical tests also in the slides. So once we know it is acute coma state and we cannot do much with respect to treatment, then the role of palliative care also comes in with respect to the end of life care planning. So these are tricky situations, and sometimes difficult to handle, because patients generally don't accept the family members are wanting us to do something. So that is the reason that he has clearly illustrated the examination part of it, because we need to be really sure, and it should be really documented, that these are the parts which were examined, these were the findings, and these are the possible causes. So, well, there is one more question. Is it time to replace GCS score with 4 score? Rajesh Mahajan. It will be difficult to say that because GCS is more widely accepted as of now. Everybody knows what is GCS. But as an adjunct with GCS, 4 score could be used, because it is more explanatory, and you get more insight into what does the score mean to us. So as of now, we should be using both till we have clear guidelines that 4 can replace GCS. Any more questions? I think we are just in time. Ma'am, any comments from you, ma'am?
yes, so I think this is very important class, and Karanvir has explained. Uh, I think in a short time he has explained a patient who has presented in a altered sensorium plus in an unconscious state. So thank you, Karanvir, and it was a very nice presentation. And the last question and the answer, I think this is very important regarding the question was that what should be we documenting in unconscious patient. I think whosoever is working in a critical care area or in palliative medicine or emergency medicine, I think we will keep on getting such patients. It is important that we should be having a history before we start, that what is the past history of the patient. If patient is of any chronic debilitating conditions like cancer, the documentation will go in a different direction, and if suddenly patient has presented in an unconscious state, documentation will go in a different direction. And maybe the way he has asked, that can we circulate what should be the steps of documentation in patients. I think, Karanvir, what I will request, based on your slides, you should make a flow chart and show it to a neurologist of your colleague, whosoever. It's like we go every day, every month we have a posting. Show it to the neurologist and check. They should check that what should be the way of documenting a patient who is presenting in an unconscious, whether he is a cancer patient or in a advanced stage of any disease, and or otherwise. And please, post in the group, so everybody will be knowing that what should be the flow of documentation when patient is presenting in an advanced stage. Thank you very much, and it was indeed a nice presentation. We don't have any other questions, so thank you, Nishkarsh, and thank you, Karanvir. We will see you next week before 6:30 next Monday, and have a nice week. Thank you very
Thank
much.
you, ma'am.
Thank you, Archana. Thank you, Nisha, and thank you all the audience. Still people are there, so thanks a lot. Thank you.
Thank you.